turn your camera off. People keep on joining us. So yeah, let's make a start. We're joined together today by Thomas and Robin from Alicare. Alicare is the company that specializes in acoustic monitoring solutions, and we will be working together with Alicare to help Dorset care homes, and by Dorset I mean the whole of the ICS, so that's BCP Council and Dorset Council, help them introduce the Alicare solution in their settings. Thomas and Robin will talk about the solution. We'll talk about the benefits of the system, and at the end, I will sort of give a quick explanation of how the funding works, what's covered, what's not covered, how we will go about reimbursing you, etc., etc. So I'll pass it on to Thomas. Thomas, the floor is yours. Do your presentation. All yours.
Thank you very much. Right, so I got to I got to get the slides going. So, slideshow. Sorry, it's not letting me share at the moment. 1 second. There we go. Right.
It seems to be working now. So yeah, I can see the presentation.
Made it. All right. So I'm going to give a presentation, but I hopefully will cover it in about 20 minutes or so. So that we have some time for questions and a bit of discussion. I'm personally open for if there are questions that are just you want to raise in the chat as we go through, and we can have a conversation. But I guess what I'll do is I'll start by trying to give you an overview of what we do as a company. So we're Ally. Our purpose really is to help transform your residents' lives through a monitoring system that uses sound and motion in residents' bedrooms to help you understand their needs when they're alone. I'll go through a company introduction, a little bit about us, of how the product works and the integrations that we have, some of the impacts and benefits that we've done, and the magnitude of the research that we've done with the NHS, some wider insights, and if we want, we can get into the implementation and how care homes have benefited from benefited beyond just improving residents' care and lives. So this is a little bit out of date, but we work with over, I think, 4,500 beds now in the UK, and we've prevented a lot of falls. We've enabled a lot of falls to be responded to faster, and we've also helped a lot of care homes get a lot of time back and promote better sleep and privacy for residents. So as a general rule of thumb, we're really proud of what we've been able to do, and we like to, and we replicate that with every care home that we work with. So why did we start the company? Well, myself and my co-founder had relatives that essentially didn't receive care when they were alone at the right time. And for me, that fell into two brackets. That was the bracket of, okay, there was an immediate problem, like an unwitnessed fall that needed responding to, and the family or the carers just simply weren't aware of it because a call button or a pendant hadn't been used or couldn't be reached. And then there were the other ones, like just things have been missed. So they were feeling upset or down or more agitated, or that they were developing, say, a chest infection, they were coughing more, or they generally were developing a UTI and using the bathroom more. All of these little signs and changes are essentially missed when you're not around, and they're not necessarily communicated by, at least by my relatives. They didn't want to be a burden on us as a family, or didn't want to be a burden on the care teams when they were really stretched and really busy. Within care homes, my grandparents, as a consequence, had timely checks by staff when they were alone in their rooms. And that I could see was having some quite negative impacts on both their privacy and their independence, but also on their health and well-being from an element of disruption, just waking them up, creating more risk. They were less healthy and happy during the day, but they were also more awake and disrupted during the night, which was creating risks for them that led to things like falls. And what I realized was that basically the systems of you rely on a button to be pressed or a pressure mat to be stood on that could be easily gotten around, basically you missed an opportunity to intervene, or you simply didn't know. So our goal really is, as a company, to enable a safer, more responsive care, but also to give some unique insights around that changing well-being, to give residents better privacy and better sleep, and that as a care team, we are able to plan care better, but have more time for those residents that need it. Right, so this is us. We install a little device. It's only about 10 centimeters square into each bedroom. It has essentially a microphone and an infrared motion sensor in there. And what that does is it profiles the residents' movements and sounds they make. So you might have a resident that's sat in a chair and is calling out for help. You might have a resident laid on their side in bed that's in pain. And that can be picked up by the sound, or you might have a resident that's moving to get out of bed, and that can be picked out of the movement. What it means is that you get a lot of information because you're essentially trying to replicate what a human can do, and a human can be able to see and observe and respond. And that gives you a lot of flexibility in how you provide care. The device connects to Wi-Fi, and essentially you receive notifications on a smartphone or a PC. We advocate a smartphone where you can listen to the reason why that audio was generated, which gives some context to the staff as to what's happening as well. And then you can make a decision on how to respond. So if a resident's coughing more, you can choose to say, actually, that's informative, and we might change how we plan care for that resident, but we're not necessarily going to go and intervene into their bedroom at that point in time. So we categorize what we do into two categories. So general alerts, i.e. like call for help, panic, if they're upset or disturbed in some way, if they're in pain or they're moving, those are the ones that you receive and you can choose to respond to. And then we have an insights tool, which looks at trends and changes. So we show you how active that resident are. So has there been any changes in their sleep? Have there been any changes in the amount of the care that they've been receiving? Have they been coughing or snoring more? And then you can pick up things like other nighttime routines and agitations as well. And the purpose of that is really that you have that data set combined with what you have observed when providing care that gives that little bit of daylight that you wouldn't necessarily have. And it's been really powerful for a lot of the managers that we work with to be able to take our data set, combine it with the digital social care record, maybe the EMR system, and start to actually piece a better picture together on what's happening for that resident and be more appropriate with the care that they provide. From an interface perspective, this is just how you respond. You receive a notification on the phone, you can listen to the audio file and respond to it. And then we have our insights area, which is, this is just a snapshot. But for example, on the morning, you can see who's had a peaceful night, who's had a restless night. And then within each of these, you can dive down into much more information over what's happened as well within their timelines. We integrate with 3 care record systems at the moment: person-centered software, Nourish, and Carein. The purpose of this is essentially to sync on our alerts and notifications within PCS, Nourish, or Carein, syncing up the care notes, and also syncing up any of what we call our insights or handover prompts as well. What we found is, though, that we have all the data within our system. It obviously helps from a compliance perspective, but it also helps when you're actually like diving down into more information within the care plans. It's there as a prompt, and you can come back into our system if you need to dive down into more information. So you have a single point of I guess, truth, as person-centered software likes to talk about it. But it just helps. So you still use our app to be able to receive the alerts and to be able to respond to them and maybe write a care note around it. But they will all of that information will end up within PCS, Nourish, and Caring, which is, as I say, helps a lot with the organisations that we work with. This gives a little bit more in depth of our insights. So once you've picked out that a resident's had maybe a more restless night, the questions are why, right? So we flag up if it's that their sleeping patterns changed, or their care amount that they've been receiving has been changed, or their coughing has changed, or any other note that's been flagged on handover. You can then go and see on the timeline where they were active, different as detected by sound and as detected by motion. And go into each of those alerts and all of the details of which staff member actually responded to it, how they responded to it. So in this case, David Tutt dismissed it and said, at this point in time, the resident sounds okay. I do not need to physically go and provide care for them. And then all of that information will end up within PCS. And what this helps is it gives you at least a graphical view and also a data point to justify any changes that you want to make within the care that you're providing as well. Okay, so some impacts and benefits. So as I said, when we work with care homes, what we aim to do is really two things, right? Is we provide you a system that means it's incredibly unlikely that things will be missed within that resident's room, and that you are able to respond much more safely to those residents. As a consequence, the group care homes that we work with tend to change a little bit of their safety checks, because they find that when you go into the timelines and you see what's happening, that they are quite disruptive on the residents and they wake them up. So what we can see of our global data set is that 1 in 5 of those checks actually wake a resident up to the point where they are fully awake and may need assistance. And obviously that can create a risk. So one of the first residents we ever worked with, they, in that case, were woken up. They then called for help for 15 minutes because they wanted the toilets, but the door was shut and the staff were elsewhere down the corridor and they didn't hear it. They then got out of bed, and in the process of going to the toilet, they tripped and fell, and then called for help again verbally because they couldn't get hold of call bell. That would have all been mitigated if that resident had been left to peacefully sleep. So we work with those care homes around extending those checks a little bit appropriately for each resident, not just blanketly. And that frees up a lot of time, reduces risk, and improves sleep. So what we found is that working through that appropriately with the groups that we work with, residents have been able to have a 50% increase in the amount of time that they are not awake. And that can save staff a lot of time during the night as well. By being aware of when residents are in need of assistance before they mobilise, we've seen on average a 63% reduction in nighttime falls. I will say that actually flips. It depends on the risk profile of the resident. So if you want to allow independence for residents, we see a smaller reduction, independence to mobilise. Whereas if we see a high risk resident that you're really worried about falling, we end up, I think the average is about 85% reduction in falls at the moment. And then generally working through the care plans and the reduction in falls and the change that we made has helped reduce the number of hospital admissions within care homes quite considerably as well. So I'm going to give you an example. So this is one 66-bed care home. What we tend to do is we do a little bit of research looking at the 6 months before to the 6 months after on falls, because that tends to be a focus on this funding. And what you can see here is that there were 38 falls in this care home before we went in and 13 after. And what you'll notice is that it starts to trend down. And that is in part down to the fact of getting used to the system, but also in part down to the fact that they're able to promote better rest and better sleep, which reduces the risk of that resident being active. We do little bits of insights, right? So, for example, we look at like falls by time of night. And this has been quite helpful for this care home that we did. They started to, it was a larger care home being 66 beds. So they started to look at things like, okay, well, if we're having more falls around the time of personal care, so between 9 and 11, and between 6 a.m. and 9 a.m. What can we do about that in terms of restructuring our staffing to reduce the risk in these areas, knowing that actually during this time of 11 p.m. until 6 a.m. or 5 a.m., it's actually much lower risk as a consequence of having the system in better sleep. Just pointing out here the difference between the impact that we have on high risk and falls risk, low risk for residents. So this can be a bit of a misleading slide in some respects. It's really positive, but for the low risk residents, we tend to see that a smaller reduction because you're promoting them to mobilise. You'll still have an accident, and it might have an accident and be aware of it within our system, but obviously you might prevent fewer number of falls, as you can see. Okay. Some general feedback that we've had is that from Sue here, I think it's a really good example. She was one of the first managers we worked with, was around really completing the care picture. So I can't stress how helpful it is to have that data set of when a resident is alone. In this instance, she had a third of her residents who they just couldn't figure out some of the reasons why their well-being was changed, or they couldn't improve it. And once our system in place, it started to make sense that they were either awake much more during the night, or they were upset at times. If they had dementia, it seems to be quite common that a resident, after going to bed, for example, will say, "Help me, where am I, what's going on?" And they can change how they work with that resident and what they do during the day. And that's been quite a big thing that we've seen across our managers in terms of taking the data out of our system and applying it to their care plans. So, for example, as you say here, we used to have a resident who started to often sleep during the day, and they basically just realized that the kitchen fan at 5 a.m. was waking them up. And since they went to bed at about 1 a.m., they weren't actually getting a huge amount of sleep. So they first started by changing how they were working with the kitchen, so they didn't have the fan going on, and then they moved the resident to another room, so it was much more likely that they could get a longer period of sleep. We can go through a lot more of these as if you have any questions as time goes on. But I like some of these from Oakland's Rest Home. So Ally alerted us to a suspected UTI, and that was really just because the resident was much more disturbed, agitated, and active than they had anticipated. So they started to ask the questions of why are they using the toilet more? What are they doing? Whereas with this one, they had a resident who'd been coughing more than usual, and they went, okay, well, that's quite a big change. They tested, they found that they had COVID, but they were also developing a chest infection. They could start moving that through the process of actually trying to deal and combat that as well. Okay. I'm going to actually stop at this point because I think it's a good point to ask questions as well. There's more to the presentation in terms of around how we implement as well, which we can cover, as well as how care homes have tend to see, like, I guess, the impact financially from us. But I don't think that's necessarily worth covering on this call. So can I open this up to if anybody has any questions?
Don't be shy. This is your chance to dive deep into Thomas's mind and ask him how the system works, have your questions answered. Okay. There you go, Mel.
Oh yeah, thanks for that, Thomas. That's really interesting. Can I just ask a little bit around sort of installation time, how that kind of works and how long it takes, that type of thing, and how's it communicated with the families of residents as well? How's that kind of tackled?
Cool. And let's go to the implementation slides. So what we basically do, right, is we do a kickoff call with you as the care home and also any wider team that wants to plan implementation, what you need to make changes to your care process, right? So, for example, some organizations we work with, they simply can't change the regular checks. They're not sure how to embed the data within their pathways. Can they make changes and go back to justify changes, things like that? So we just make sure that we have the right people involved for you as a home to exercise those benefits. We'll also do a site visit as well. So that site visit is basically us coming on to check if we can if there are going to be any technical issues when we install the product. So that is, we get one hardware unit installed online on the Wi-Fi, we get the app installed on one phone and we on one computer, and we basically just test, is it functional, right? Or are there any limitations? And if you have a integrated software as well, with PCS, Nourish or Care in, we can also test that integration. We then go around the remainder of the home and we pick installation points within each room, making sure that there's a power socket available. There's an appropriate location, because we do use motion as much as we use sound. So there is some determining factor on where we'd like that, and that there's a strong enough Wi-Fi signal. So that's a big thing for you guys to consider, is if you have strong Wi-Fi signal, we don't worry at all really about upload and download speed, because we're very minimal on the data that we pass. We'll sit down at the end of that and just say, are there any items that might need to be addressed? Like, you can go into rooms and find there are no power sockets quite often. So we just have that conversation. You'll also get from us a template consent or GDPR consent package. So that basically has information around us as a product to give to the resident if they are deemed to have capacity to consent to this. If they're deemed to not, then you can go to your LPAs with information and a consent form and get consent there. And then obviously, if there is nobody who has the power to consent, you would go through a best interest process. Because that takes a little bit of time, and because it can take a bit of time to be able to arrange training as well, we tend to find 3 to 4 months. That's a massive typo, isn't it? Weeks. Don't know who wrote that slide. It will basically be 3 to 4 months from the site, or 3 to 4 weeks from the site visit to us doing installation training. And actually, sorry, 3 to 4 months is the amount of time that we would expect it to take for you guys to embed our system in as part of your processes. It can be a lot quicker than that. It can be 6 weeks or so, but we tend to find there are stages. First, you want your staff using the system safely. Then you want to make sure that you can reduce sleep disturbance. And then you want to make sure that you're working through the insights and data that you're getting into your processes around how you're changing care plans. Do you have multidisciplinary team meetings, or what it is that you do within your care planning process to prompt these changes that you want to make? And then we tend to do a benefits review, which we will need to do with your homes as part of this funding. That will tend to focus in around falls, because that's what the funding is about, but we can also look at wider benefits as well.
Thank you.
Thank you very much, Thomas. May I jump in with a couple of questions?
Yeah, go for it.
Okay. So the device can be switched on and off independently, right? So you go ahead, you install it in a room or across a unit, across a wing, and if for whatever reason a resident does not consent to the device, you don't have to unplug it. You can simply uninstall it, correct? You can simply turn it off, correct?
Yeah, so essentially every resident has to have a profile on our system. The first question that's asked is, do you have consent or best interests in place? Mm-hmm. If you don't, then the monitoring cannot be used. When you're actually using the system as well, we operate on an on-off basis. So if I go back to, we are probably, I don't have a screenshot of it here. We operate on an on-off basis. So essentially, when the resident's alone in their room, you turn the monitoring on. When they're not alone in their room, you turn the monitoring off. If you have a staff member with the room, you can pause the monitoring as well by simply clicking, I'm responding to this person, I'm with them in their bedroom, and then you can complete that afterwards. So you are only receiving notifications for that resident's needs when they're alone within the bedroom and they have consent. You can't do things like listen in live because there's 2 reasons. Number one, if you do that, it can give you a false understanding of what's actually going on for that resident, because you might just hear nothing at that point in time, whereas 10 seconds earlier, they might have been in pain. And secondly, we think that's a breach of privacy that you could do that without a justified purpose, when we have an algorithm within the product that is essentially saying this resident is calling for help or in pain or moving, and therefore you might need to provide assistance to them. That is that has purpose behind it.
Okay, that makes sense. You touched on the algorithm. That leads on to my next question. So the system learns the resident over a period of time?
Yeah, so we have an out-of-the-box algorithm that basically says this is what residents sound like globally. And then as time goes on, essentially the algorithm personalizes it more to that resident. So we try and filter out things like background noises from corridors and things like that. But there's an element of feedback within the system. I will point out that we basically have 3 categories of alerts that you'll end up receiving. So ones that you need to respond to immediately, ones that are insightful around their well-being. For example, ones that you'd respond to immediately as if a resident's calling for help or in pain, whereas one that you might not respond to is if they're coughing or in some form of agitation, or if they're not a mobility risk and they're moving around, you wouldn't respond to that and go and provide care. And then we do have a third category, which is that it's actually neither of those, and it's just a false positive. That gets much smaller as time goes on, but it does still exist. And what you'll end up finding is in an 8-hour window, there'll be on average 5 alerts for residents, of which 1 will need care, 3 to 4 of them will be informative about their well-being, and 1 will probably be something that you don't actually is not necessarily relevant to that resident. But that's because our algorithm errs on the side of caution about that resident, and obviously they're quite residents' needs and how they sound and how they move are quite adaptive. So we're constantly having an adaptive algorithm, but if we miss something, that's more of a concern than if we send you what we'd call a false positive, basically. Okay.
So the algorithm will identify the alert, categorize it, and send it across. Does it come? You get a visible alert on the handheld device. So the homes that we're going to be working with are already using a DSCR, and their staff members will have smartphones used for this purpose. When the alert is generated, does the staff member immediately know if it's something that they need to respond straight away, or do you get a blanket notification, new alert?
So at the moment, you get a blanket notification,
okay,
because we often find that within the sound, there are nuances that are relatable to that residence. So it's worth listening to the sound. So we make an active choice not to put a written description of it because of those nuances. That's what we make as a choice. It takes a few seconds to review and go through the audio. It's definitely worth it to be from a safety perspective and also from a privacy perspective, and to try and reduce the disturbance on that resident.
Okay. I see a hand up from Umer. Umer, if you want to come in with your question.
Hi, I've got a couple of questions. The first one's sort of analysis, things like response times. How easy is it to pull that information out of the system?
Yep. So we give you, so we have a lot of reporting, as you can imagine, because we are able to see obviously which staff members respond to the alerts, what their responses are, etc. So we give you a daily report that comes into your inbox. Basically just looking at staff's average response times, how many alerts and notifications are they dealing with it, how this breaks down by zone as well. We give you a weekly summary as well and a monthly. All of those are in email just because they're quite digestible. But you can jump straight back into the software and look into more detail. So you can see if there's been any larger response times, you can visually see within the timeline here. And what we also do is we give you some, I guess, what we call a benefits and impacts report on a week-by-week change on how that looks from an overview of the entire home as we're going through the adoption period. So we have a lot of that built within the system. I will say that we also have a feature request list in terms of diving deeper. So for example, heat mapping, how busy staff are at certain times is maybe not the easiest. You can't actually see that within our system at the moment. You can only see how each individual staff members are performing. But we have a development team that work on these new features constantly, and we aim to produce one major feature upgrade to the software each quarter, and 2 or 3 smaller ones as well.
Yeah. So like the deeper dive, I'm guessing that's things like the home manager could look at instances where a member of the team looked at the alert and felt they don't need to be in the room. And on the other hand, look at how many alerts actually led to a physical presence in the room and how long that took.
Yes.
And then my lead on question from that is, how does it link in with existing sort of call bell systems and things? Is it, because I'm guessing this is a complete replacement, or is it?
No. So we don't have a button to press within our system. It is entirely based on sound and motion, right?
Okay.
And so we are alongside your nurse call. We don't integrate with your nurse call. We integrate with your digital care record systems. We focused on doing that first because of the information that you can get out of our system is more associated with the care plans that you use. And secondly, for the residents that you're using us with, you will have fewer nurse calls being used at the time that our product is being used when the resident's alone in the room, because you'll be receiving notifications around their needs before they make a choice about it, but not always. Somebody might whimsically want to press a call bell button because they want a cup of tea, and there's nothing of concern building up to that. So your call bells will still be used. They should be used less because of our system being in place, but we don't have nurse call alerts coming through on our system, and we don't send our alerts to a nurse call system because you wouldn't be able to listen into them. The interface just doesn't work. And we thought the greatest value add that we could provide was integrating with the digital social care record because of the level of insight that you can get out of what how the residents' well-being is changing.
Yeah. Then I've seen other systems where they've got an element of video monitoring as well. And I know you said you don't have live audio. It was basically live video to a certain extent. And they have, the home in question had someone who basically sits at a computer all night, just flicking through screens, monitoring, responding to acoustic signals. Is that something Ali has or doesn't have? And would that be coming, not coming?
So we use sound and motion, right? But our motion's infrared. We do not have video. We've spoken about it a lot as a company about the various merits of video. And essentially, because our results are really quite good. I mean, for high-risk residents, averaging an 85% reduction in falls, and in general, 63%. We're really, we think that that's pretty darn good, bearing in mind that you also have to make choices about residents' independence, right? And that comes out of simply using infrared and sound. The problem with video is just, you have to ask yourself from a GDPR perspective, it's a bigger invasion of privacy than just receiving a little sound file of something of concern. And you have to ask yourself, is it proportional? So we've had to ask ourselves, if we incorporated it, would we expect an improvement within our results that's justifiable and proportional for the invasion of privacy on top of it? And we, at the moment, have said it's not needed, or it's not actually proportional.
Thank you.
If I may jump on, thank you, Umar. Deirdre, before I pass it on to you, we made a conscious decision with this funding to work with an acoustic monitoring provider. So we sort of also explored the video element, but there were some initial concerns regarding privacy and how invasive that would be seen. Hence, we decided to go down the route of acoustic monitoring only, just to give everyone a bit more information around our decision. Deirdre, yes.
My question is around the recording. Once the staff has got the record, obviously this can then be used for when we review the, for example. Can I just ask about the storage and how long is it for?
Yeah. So we store the audio samples of the alerts that are generated for 3 months. And they can be accessed at any point of time within those 3 months. If you need to access them for an investigation that has a purpose, so you're concerned about X, for example, you can access them. And then they're stored, we store them for another year, but we also give you a downloadable file as well that you can then store them for as long as you need. And so obviously that will help with if there is an accident that you're concerned about, or if there's an element of concern about a staff use, so long as there's a purpose that is beneficial to the residents' safety and well-being, you can access it. We make it a little bit hard, so you can't just go in and go, I want to listen to this, I want to listen to this, I want to listen to this out of curiosity. It has to be a reason, and that's just because of the residents' privacy, really.
That is beyond the 3-month period, right, Thomas? So within the space of 3 months, the manager can go in and listen to the alert, the recording, as many times as they feel the need to.
No, there still has to be a purpose. You can listen to it. It still has to be a purpose for it, because otherwise, from our expectation is that the alert has been dealt with by the staff. It should have been dealt with appropriately. There's obviously a question over whether, if there's a question over whether or not staff are dealing with alerts appropriately, you can investigate. Therefore, you can access that audio, have it downloaded, and review it as many times as you want. But we do put up a wall saying that essentially you need to have a purpose. You can't just, out of curiosity, have a listen, basically, because your staff should be responding appropriately. I'm aware that that may not always happen, and there's an element of comfort needed, hence why you can go and listen. But I just want to stress from that's the design from a GDPR principle perspective.
Okay, understood. Thank you. Deirdre, your hand is still up. Is that a legacy hand or?
I have one more question. So let's say we have the A in our care home, and obviously we've noticed a lot of intervention needing for that person, and you then want to review the care package. So you just say that if we were to go to a panel, or the family wants to use this information to justify the care needs, for example, CHC, we all know that. So you are saying we would have to come to you to get that information, because obviously we won't be able to access it, and it does take more than 3 months.
So long as you need to access it for an investigation reason, you can access it. Absolutely. Okay. I just wanted to say that, like, you can't sit there for 4 hours just going back over timelines. We say we have some restrictions that say specify what you want to see, what's the reasons, what's justification. So let's say that you're concerned that a resident is more agitated or in pain more than usual. You can specify that time frame and have access to those audio files and download them. But we just we've designed the product so it's in the power of the resident, because it's the resident's data, and therefore any further access beyond what you were doing at the point in time is for their benefit. So yes, Deirdre, you can have access to it, but you just need to justify it. You just need to justify it. So, we are holding the data on behalf of you as a care home, right? But we just have some principles within here around the residents' privacy in line with GDPR, because I think that is important.
Thomas, all these aspects of the relationship between the Ally Care and the care home are documented within your standard terms and conditions?
We have standard terms and conditions over essentially how we're holding and processing the data on behalf of the care home. It's like, okay. Deirdre, you can literally turn around and say, I want all of the audio for the last 3 months for this resident on every single alert that was generated, and I want to indefinitely hold it. That's also your choice as an organisation to do that, and you go ahead and justify it. I'm just trying to say we try and put some breaks in so that there's some thought put behind it. But yes, it's detailed within our terms and conditions.
That's good. Because I have to also stress this, the way the funding works is as a reimbursement. So we are asking the care home to embark on a relationship with Ally Care, which will be done on the standard terms and conditions that Ally Care offers, so their contract. The care home will then install, set up, pay for using the sensors for a period of 12 months, and we will then be reimbursing the care home up to a total value of £10,000 per location. So there's going to be two contracts involved. One side of things deals with how the care home is interacting and engaging with Ally Care, and the other side of things is how they interact with Dorset Council, who is acting on behalf of the whole ICS. So there's going to be a grant funding contract for in place between ourselves and the participating care homes, and the standard terms and conditions for Ally Care and the participating care home, upon which the service and the product is being delivered. Any further questions? Go ahead. Go ahead, Didi.
I know, Alex, right?
That's okay, it's fine. You know, I like it when people engage
right.
and ask questions. So yeah, that's your chance. Go for it.
Okay, I don't know if it's the right time, but could we have an idea on costing, licenses? Because obviously this is a project that's going to go beyond what the ICS is offering. So can you give us an idea of licenses immediate and after, please, both?
Yeah, so we operate a license fee, which is slightly different to software, because software licenses are normally just software and support. So we have software and support, but we also have the hardware covered under it. So if anything breaks at all, we essentially swap it out. If, however, you, I don't know, put it under, smash it with a sledgehammer, there's a £50 or £55 replacement fee, and that's it. The subscription fees are either £9, £11 or £13 per device, also per bedroom per month. That depends. So we have slightly different software packages. The top one has the integration, so that's £13 a month. But what we have at the moment with some other ICBs is we have a tiering as well. So the first year is 100% paying. If you go into the second year and you continue with us afterwards, we have a discount, and then we have a discount in year 3 as well. And then year 4, it goes back up to 100%. And I think it's year 1 is 30% and year 2 is 15% discount.
If I may interject, usually the higher costs are in year 1, because that's when you look at the site survey, you look at any possible installation costs, you look at the training. So the fact that we're giving out money in year 1 can act as a significant sort of financial contribution in terms of your overall costs. Year 2 and year 3 costs, you're basically dealing with the subscription for the existing units in the care home, and it's a manageable expense. I mean, based on the information that Ally Care has given us as part, because we run a tender process for this, we don't expect prices to shift in year 2 and year 3. So we've been quoted a price for the ongoing subscription cost per 10 sensors. That's another thing I'd like to stress out. We will not be exploring cases of installing a sensor here and a sensor there. We're looking at a minimum of either 10 sensors per care home or a whole unit, a whole floor, but it would be very difficult and would defeat the purpose of this funding to have homes installing just a couple of sensors.
Yeah, and then really I'll just add to that, which is, as a company, we tend to have a philosophy of you're making a bit of a change culturally to more virtual care for those residents, fewer safety checks, but obviously you're still doing pad checks, turnings, but you're trying to essentially set the philosophy of giving as much privacy and rest as possible, which will free up time for your care team to be with the resident when they need it. And you're also targeting being preventative about the care that you provide. So we tend to say minimum we do a unit, because then you get to see around the immediate safety benefits of, say, preventing falls by being aware of a resident who's in need of assistance pre-mobilizing, or being aware of the fact that you have a sleep problem, an agitation problem, or coughing problem, and how that might impact on their care plan, and be able to plan care better for them. And if you do it on an individual by individual basis, kind of annoys me as it frustrates me as a founder, because then you're not doing it from a preventative perspective. You're doing it more based on I see this one resident has a falls risk, or this one resident has a chest infection risk, but then what if this resident over here suddenly develops a falls risk? Well, it's normally as a consequence of a fall that you reassess that to some degree. So we're trying to promote that philosophy of prevention. So we'd say at least do a unit, and realistically, we normally find it better to do an entire home. There is no commitment beyond year 1 as well, but obviously you've asked about the costs going forward. So we would expect you to be able to see all those benefits, and we'd work with you to show you those benefits and help map them well before we get to the end of year 1, and if needed, to build a business case on how this is impacting you. From, are you able to shift to the twilight, or what some of the managers call the twilight routine? So if you've got a bigger home, you might be able to have staff member on personal care beginning of the night and the end of the night, and they shift down a little bit in the middle. Are you able to use it to promote and increase your occupancy? Are your team happier? So we hear a lot about day teams being happier because you've got residents that are easier to interact with and manage. There's can be less challenging behaviour. So you get quite a lot of range of benefits, but it's just a question of how you make sure it's propagated. So, Uma, you've got your in fact, Uma and Deirdre have got your hand up. I don't know who went first. Alex, do you know?
Well, Deirdre, is that a legacy hand, or do you have a follow-up question?
No, just one follow-up question, please. Tom, did I hear correctly? You said that £13 license is the one that is integrated with either PCS or Norwich. Was that correct?
Yes, that is the one that is integrated with PCS and Norwich. Yes.
And Umar, you had your hand up before.
Yeah. Is there any opportunity to see like a live version of the system that's been implemented anywhere?
Yeah, so the purpose of this call was just to try and introduce the wider system, the concept around us capturing unobserved care needs and how you can filter that through your care planning process. In terms of seeing a live demo, if you get in touch with us, we can arrange for one of our colleagues to give a demo. If you give us information ahead of time, if you have a system that is PCS, Nourish or Caring, we can also show in relation to those systems as well how that functions. So
and then my other question is, not just operating in Dorset, you're nationwide.
Yeah.
In terms of the system.
Yeah, we're not. Yeah, we're not just Dorset. So we operate across the whole of England in pretty much, I'd say, every council and Wales. We're not in Scotland, but as yet, but we can provide Scotland. It's just logistically harder for us. As I said, we're in 4,500 beds. We've been going essentially for 4 years since beginning of 2020, so 4.5 years. And all of the results that you see are done. The research and everything is done across a very large scale with multiple ICBs. So we're just starting work with Dorset, but we've done a lot of work with other areas like North Central London, Bedford Luton and Milton Keynes, Hampshire, Herefordshire. It goes on around the work that we've done. So we are not just Dorset, we operate nationwide, just not yet in Scotland.
Right, thanks.
Brilliant. Are there any further questions? Anything that you'd like Thomas to expand on? Anything that you'd like to ask me regarding the funding or how it works?
Probably, Alex, the only one thing to add is that if you are interested and haven't submitted an expression of interest to Alex, can you please do so? Because then we can work through those and come back to you on next steps.
Yep. By the 11th of October, that's the deadline for submitting an expression of interest.
But the sooner the better.
Yeah, and we are definitely here to answer questions. So if there are questions or demonstrations that you want in more detail, it's hard to do everything within a group. So please do message us and we can arrange that in advance of the 11th. In advance of the 11th of October, definitely.
On this note, I will stop recording